Good morning. This is the first live broadcast from the Seniors United Party of Australia's Facebook page. Who I have with me this morning is Dr. Yvonne Mcmaster. Dr. Mcmaster is a long-term advocate for palliative care in the country and has a background in palliative care. So I invited Yvonne here today to talk to us about palliative care overall. So Yvonne, can you please tell us what is this thing called palliative care?
Well, the word palliate means to relieve. So palliative care aims to relieve symptoms and to relieve suffering and to relieve stress and other things. And a nice sort of little summary of what palliative care is. It's the difference between living as well as possible until you die or suffering until you die.
Okay, thank you. I've always associated palliative care with cancer. Is that right?
It used to be. Palliative care really came into existence in the 1960s in England. People at that time were suffering dreadfully with cancer, really terrible suffering. And a nurse, who then realised she had to become a doctor to get anywhere, tried to find better ways. Her name was Cicely Saunders. And she started this new way of looking at pain to ensure that pain in cancer can be controlled. I went there and studied with her in the 1970s.
Oh, okay.
And I was really then the first person, one of the first people in Australia to bring her new knowledge about pain management here.
Okay. Okay.
And at that time I had started to work at Naringa Hospital, which was my local hospice.
Okay.
And so I spent then years introducing her methods, convincing people here about them. Some of them were very resistant to the idea that you could give morphine, for instance, for pain and not kill somebody.
Oh, okay, yeah, sure.
But in fact that it could be done very safely and people could have a really good life when they were pain-free.
So it's not just about cancer, it's really about end-of-life care.
I'm glad you reminded me what your question was. That was that gradually we've come to realise that palliative care is needed for other things,
Okay.
Not only for cancer. But the other thing is, life's changed so much since the 1960s.
Sure.
People used to drop dead with heart attacks a lot.
Mm.
They'd have car accidents. They'd die from infections. And nowadays medicine is so terrific that people are living very much longer. That's a bit of the basis of why we're all living so much longer. And in the end, though, we're in decline for a long time. And in those years of decline, either your heart fails, or you get cancer, or your lungs fail, or your kidneys fail, or you just get really frail.
Sure.
And we all need extra help
care
at that time.
Okay.
Some of that is palliative care. So palliative care, helping people with their symptoms and supporting them and their relatives throughout the whole process, which can take years. So when you say it's about end of life, it's really not just end of life. It really should start as soon as somebody's diagnosed with a condition that's going to limit their life, so cancer or heart conditions and so on.
Why do you think people don't like talking about palliative care?
It's a very interesting and complex question, isn't it?
Mm.
It's very, very much grabs you where you live, doesn't it, when you talk about dying?
Mm.
And people associate palliative care with dying always. That's how I started out with doing palliative care. It was people at the end of life. But now, people aren't dying that quickly. They're taking a lot longer. And so, I think there needs to be a realisation that palliative care doesn't mean dying, that it's actually something to help people live much better.
We're told that through surveys, about 70% of people would much prefer to die at home. But we know from government figures and health department figures that fewer than 20% of people actually do die at home. Why is that, and what can be done about it?
It's a very complex question. First of all, is that right? Are the figures right? I think if you go to the man in the street of all ages and say to them, where would you like to die? Golly, I haven't really thought about it, have I? And I'm not really sure. You know, I think I'd just like to go to sleep one night and wake up dead. You know, so, you know, as if that's what the end of life is like. People don't really realise what the end of life is like. Dying the way that we die nowadays is not like what you see in the movies. It takes a few days. So there's a few days of people being very disabled. So you might have, I would say to people, you know when this is with cancer particularly, you know when the end is coming, because gradually your life shrinks, your world shrinks. Initially you're going overseas, going around Australia, going to the shops, that all contracts. Then you don't go out to the shops, you're not well enough to go out to the shops on your own, you can't drive the car anymore. You can find to the home, and then you can't get out of bed. And then that's when you need most help. And then gradually you sleep more hours every day, usually become incontinent, maybe become a bit confused, and at that time you start to go to sleep all the time, and eventually people die in their sleep very peacefully with a bit of assistance if they have the right help. And it can even happen without the right help, you know. People do what they'd most like to do, go to bed one day and don't wake up, but it's a very rare thing. So that's the basis of that theory. And what there's been research actually with people as they are dying and asking them, now where do you want to die? And gradually as they get closer to dying, they realise how difficult it is to be looked after in those days, those last days at home. And it becomes too hard for their relatives, or they're realising that it's too hard for their relatives, and they say, I'd rather go to hospital now. And so we do need places like hospices where people can do that, like those last days. Or we need very, very special help. But even with special help, sometimes it's impossible.
Yeah. We all hope that we'll be able to manage in our own homes, close to our family and friends, right up to the end of our lives. What should we be doing to ensure that we'll be able to do just that?
A lot of thought myself, I have to say, because here I am, 76, and I can see myself not doing as much as I'd like to do, and I can see the future. And here I am in a three-level house and garden, and very inconvenient. I've seen people manage in places like this, but then I'm thinking myself, I'll move my bed onto the ground floor, and I'll get people in to give me grab rails in the bathroom so I don't fall over, and assess where the stairs are, so you know it makes it easier to get in and out. That initially you can set up things in your home. You also need to look at who your helpers are, who can help you. I think it's good to have a good family that can be part of it. It's a very important part. I think we need to have a conversation about what our wishes are. You know, what could we put up with? And even that's a little bit difficult, to be frank, because we don't know until we're in that situation. So
it can be quite confronting for family and friends, can't it?
Absolutely. Somebody dying?
Oh no, having that
conversation. Absolutely.
Yes.
I'm part of a family that knows all about what I'm, dealing with. But I invited them to come and have a death over dinner discussion with me. Oh no. Oh Mum, don't keep talking about dying, they say. So I said to my son, I've got a creek here. If I suddenly discover that I've fallen in the creek and drowned, don't be sad. They say, well, don't talk about dying all the time. So it's painful for them.
It is.
It is painful to talk about losing people that you love.
It is. If someone can't manage at home, what are the options that people have available to them?
They are very few, really. Fortunately, there are some services that help us in the home. So government funds some services, or we can pay for services so that a carer or somebody can come into the home and help the person. Somebody's going to have to come here and help me make my bed one day. I know that. For instance, but there's a lot of services that we can have. I mean, there are people who help us with gardens, easy care gardening groups and that kind of thing. But when you can't manage anymore, when you get really frail, or what happens usually isn't just that. We don't usually have the insight, any of us, to realise that we're not coping. Our families start to get worried about, maybe they'll come and find us fallen over, and we'll have been there for hours. So there are things, there are electronic devices that we can wear around our necks and so on. All these things help. But the other time that you realise that the end is coming is you'll have a fall, maybe break a bone, and be taken to hospital. Or even if you don't break a bone, and they see you in hospital, these healthy young doctors and nurses see you in hospital and they think, this person could never possibly manage at home. Poor old thing. We'd get them into a nursing home. And they've got to get you out fast. Beds in hospitals are very precious things and very expensive things, and they don't really want frail old people in them. They want out to go. They go. So into a nursing home you go, and it might be you get stuck there. Some people can fight their way out, but it depends, really. It depends on what supports they have. So then we have to think about nursing homes. Shall we talk about nursing homes?
We can talk about it. Sure.
If you have a lot of money, you'll be fine. So a really good nursing home is quite a big investment. It's a big capital investment, and then it's an ongoing investment every week or every month. The care in the very good ones is very good. So there are specialist nurses who really understand end-of-life care. They've done training in geriatrics, or even some have trained in palliative care. That's very important. In general, there's not very good access to specialist palliative care at the moment in nursing homes. It's improving a little bit, which I'm very pleased about. There's one woman who's done a lot. She's in the Southern Highlands, and she used to be a palliative care nurse, a specialist palliative care nurse in that area. She saw the problem in the nursing homes. And so she decided that she'd start her own business. And her business is that she contracts to 5 nursing homes. Okay. And she goes into each nursing home 1 day a week. She spends 5 hours there. She sees the patients who are approaching the end of life or who have got symptoms or other problems that they need help with. She discusses with the nurses and the carers who are there what's needed. She speaks to the GPs and organises the prescriptions. She talks to the relatives and she tells them where this person is at, where they're going, what's happening. Maybe they are approaching the end of life. So everyone is prepared. So that when something goes wrong in the middle of the night in those nursing homes, they don't call the ambulance and shoof the people into hospital. If there's something that can be done in a nursing home, and usually there is, it's done because she's already set everything up.
Good.
So she's done a fantastic thing, and I think that in my mind, is the model for all of Australia, to have specialist nurses who can go into nursing homes on a regular basis, get to know all the people, get to be known, get to know the GPs in the area, so that everyone's working together as a team to help when the help's needed, so that it's there immediately.
Yeah, it sounds very good.
It's fantastic, but I should say that this is very rare to have this sort of situation. There are a few wonderful places where it is available, but it's nowhere near enough.
How do you think that care can be improved in nursing homes?
Well, I think that's
model.
pretty much what I'm
That's
saying.
the model, yeah.
You see, here in northern Sydney, which is where we are right now, there are 97 aged care facilities, and there are now 2 nurses going into those facilities, and all they can do is go when they're called. So when there's a problem, they can go, or they can go and give advice, or they can teach the nurses that are there. Problem is, in nursing homes, the staff turn over quite quickly in many nursing homes. So the idea that you can upskill the staff is a bit of a problem. one attempts to do that, and the palliative care services really have it now on their radar to do that, but they really haven't got capacity. You know what capacity is? Enough staff. They haven't got enough doctors and nurses that are being trained in palliative care in the very complex and detailed work that's needed to keep people comfortable. There aren't enough anywhere in Australia.
No. So with 97 facilities in northern Sydney with only 2 specialist nurses, with the ratio from the person you know down in the Southern Highlands, you'd actually need 20 to cover 97.
Yep, that's
so
right.
It's a
That's
great
right.
shortfall. There's a long way to go.
You see, I put this to Northern Sydney Local Health District, that if they employed 10 nurses to do this work, the nurses maybe would go in 4 hours. They're going to 2. Each nurse could go maybe to 2 facilities a day. So maybe 10 would cover it. And I think they would save a huge amount of money. Because what's happening now is when things go wrong in nursing homes, they call the ambulance and off to the hospital they go. Person arrives in hospital, nobody knows them. There are scanty sort of notes that come about them from the nursing home, but some sort of notes, but you know, however much you can write down in a quite a short time. And once they're and it's a scary place for people. After all, we do know that quite a lot of the people concerned have got dementia. So they're suddenly yanked out of their home and into somewhere that they're unfamiliar with and very frightening. And people don't know how to handle them. Nobody feels comfortable. There are some sorts of schemes. For instance, they've got a scheme at Hornsby Hospital called Grace, which is where as soon as somebody's headed for a hospital from a nursing home, the nursing home's got to have told the hospital that they're coming, and a nurse is immediately available to triage that person, make sure it all happens quickly, and they get them back home as quickly as possible. So there are little bits of work being done, but it needs to be a lot more. While we were talking about people managing at home, I forgot to say that those packages which are available for people at home, which help people to keep staying at home, which is vitally important for everybody, both from the person's point of view and from the government's point of view, because the costs really escalate, those packages are not sufficient. So a year ago, I don't know what the up-to-date figures are, but a year ago I was told that for every package which is available, there are 40 people waiting.
Oh, is that?
That was a year ago.
Is that what they call ACAT packages?
Yes.
Oh, okay, sure. Yeah. Well, what about palliative care units, specialist palliative care units?
Well, this is something very close to my heart. When I was just graduated, just finished school, and before I started uni, I had my first job was at Naringa Hospital, the hospice where I eventually worked for 23 years. But I went there as a nurse aide. And at that time, Naringa Hospital had 90 beds, and they were all occupied by all sorts of people. Most of them had had strokes or had dementia, or some had cancer. But that was enough in those days to handle this area, this part of northern Sydney. So there were enough people there to be well looked after. They didn't have to be chuffed off into nursing homes or anything. They were looked after for months or years. Years, and that's talking about 60 years ago, okay? Years later, when I started to work at Naringa, there were still 90 beds. And we still had people who had been there for years. We were still able to do that. Since then, and I'm talking now about 1970, since 1970, Naringa has shrunk to 19 beds.
19 from 90
beds. Wow. When people come in there, they're told that if they don't die quickly enough, they'll have to go to a nursing home. So people go into Naringa and to other hospices, not only to die, they also go in because they've got pain or other symptoms that need to be controlled. And, then they're able to go home again. So that can be that's a different function for palliative care units and hospices, which is very widely used. and very important. So they're very important to have, and there aren't enough of them. But the government has always wanted to close beds in them because the government pays for those beds. Yet the beds in a hospice are much cheaper beds, much less expensive than in an acute hospital. Quite a different thing. And of course it's always lovely to put people into nursing homes because they're paid for by the federal government, aren't they?
Yes. What problems is palliative care? You've outlined some, but what other problems is facing palliative care at the moment?
In my opinion, palliative care doesn't have enough funding. It's not only in my opinion. We've now got supporters all over Australia also crying out. Problem with palliative care generally is that most palliative care is done by people employed by the state government. They are not allowed to speak up. They are not allowed to say how bad things are. They hear the patient cries. They hear them. They see the suffering. And there are not enough of them to manage it. So the major problem is not enough capacity, not enough doctors, nurses, and allied health. That's physios, social workers, occupational therapists. They're the ones who support people to be able to manage. There are not enough of those anywhere in Australia. They're stretched everywhere. Victoria is better off than New South Wales, better off than any of the other states.
So this is a problem you get with a system that we have here where we've got a federation of states. You've got different standards in different states.
Yep.
Do you think that if responsibility was shifted to the federal government for palliative care and there was sufficient funding, it would be a much better scenario?
It might be. It might be. The federal government does have an interest in palliative care because, after all, health costs eventually come down to the federal government, don't they?
Yes.
And they do, and the federal government does do a bit for palliative care. So it has a program they call PEPA, Program of Experience in the Palliative Approach, which is an attempt to train non-specialists in palliative care. So they fund talks and lectures and other things. For instance, a GP can take up a PEPA course and do 4 days in a hospice or a palliative care unit and be paid to do that. And so they get a full sort of immersion experience of being among palliative care patients and doctors and nurses who all know how to do things. So they can learn a little bit in those 4 days. But it's very, very rare for those places to be taken up by GPs. Nurses and allied health will often take those courses up. But GPs, even though they're paid to do that, very rarely do it.
Over the last few months, it's been reported in the media that $1.8 billion has been taken out of aged care. There was $600 million taken out at the mid-year economic budget forecast, and then $1.2 billion in the budget itself. What impact will those cutbacks have, do you think, on palliative care?
I think it's devastating. I absolutely think it's a disaster. The people I talk to who work in aged care facilities are extremely worried because right now we don't have enough registered nurses in aged care facilities. There's actually no need, that there's no ordinance that says that there must be registered nurses in aged care facilities. And there's actually no rule that says that you have to have a certain staff-to-patient ratio. So operators of aged care facilities, with less funding coming in, are going to have to save that money somehow. Are they going to cut the meals? Maybe. Are they going to cut the staff? Very likely. So what the aged care facilities will be looking at will be having as few registered nurses as possible. They've already got too few, so that's going to be horrendous. And that means, why do we have to have registered nurses? Because we need registered nurses to provide medications, to give patients medications. If you're dying with whatever it is, cancer, heart disease, whatever, you will have symptoms. And so you need to have as required medication. So that if you're in pain, somebody can give you something for the pain. Unless there's a registered nurse there, that doesn't exist. So it is absolutely a disastrous change.
The Seniors United Party held a public rally earlier this week last week in Martin Place to protest and raise the issue about the state government's proposal to make it easier for operators of nursing homes not to have registered nurses, because I think New South Wales does have some sort of proviso that nursing home operators must have a registered
They used to have. They've cut that.
Okay. So there's been an ongoing campaign about that. So in accordance with the answer you just gave, it seems that it's almost essential that nursing home facilities have registered nurses.
It is. Yeah. It is. Absolutely. Right. But unfortunately, the state government, they held an inquiry, and the inquiry recommended that they do continue to have registered nurses. An obligation that aged care facilities must have a registered nurse 24 hours a day. But the state government decided to take that rule away. Now, I've had a lawyer look into that who has said that it may not be the right of the state government to make that rule because aged care facilities are run by the federal government. So it's really the federal government we have to impact about it, not New South Wales, I think.
I think that's the argument of the state government. They see that aged care facilities are a federal government responsibility, and that's why they've made some decision to opt out of having a requirement for registered nurses.
But my advice was that actually New South Wales doesn't have the right to make that rule.
Yvonne, is there anything else you'd like to say? We're coming to the end of the interview. Is there anything else you'd like to say?
Yep. Palliative care is wonderful. There's not enough of it in Australia at the moment.
Okay. Is there anything you'd like to say about the organisation, like Push for Palliative?
Yes, I'd love to. Well, Push for Palliative is a group of people all over New South Wales and in the ACT, and we have somebody in Victoria and more scattered everywhere else who really want to see palliative care be helpful to people, who are also fighting to have more doctors and nurses and allied health from palliative care wherever a person might need it. And we've had a petition going asking the state government, the New South Wales government, to provide enough funds for palliative care for people, whether they want to be at home or if they're in an aged care facility or an acute hospital or in any other place where there should be access to palliative care. We've had over 83,000 signatures.
Wow, 83,000.
Handwritten signatures. We've had our third debate in Parliament, in New South Wales Parliament, about it. And there's still no move from our state government to increase the funding at the moment. They say that they care about palliative care and they're very concerned about palliative care, but then they're still not doing enough by any means, particularly in rural and regional New South Wales.
Yes, certainly. We might wrap up there, Yvonne. I've been talking with Dr. Yvonne Mcmaster, OAM, who's got a strong background and expertise in palliative care. My name is Chris Osborne and I'm the chairman of the Seniors United Party of Australia. And this will be a first in a series of live broadcasts and interviews on topics and issues directly related to seniors. And that's what the Seniors United Party is about. It's about raising issues directly that impact seniors out in the community. Thanks very much, everybody.
Thank you.